All right, so I think we can get started. So hello everyone, thank you for joining us today on our second live Scoping Sunday session. We have more than 350 people that have registered so far from all over the world, and we're very excited to have you all join in today. My name is Ramzi Mulki. I'm an advanced endoscopy fellow at the University of Alabama at Birmingham, and I'll be co-moderating this session today.
And I'm Jacqueline Chu. I'm a gastroenterology fellow at Mass General Hospital in Boston, Massachusetts, and I'll be co-moderating with Ramzi.
So for those of you who are not familiar with us, Scoping Sundays is a Twitter account founded by Dr. Muhammad Bilal, who at the time was an advanced endoscopy fellow and now is an advanced endoscopist at the University of Minnesota at the Minneapolis VA. Scoping Sundays is led by a tutorial board composed of a group of gastroenterologists in training and junior faculty who share the same passion for collaboration and education, especially during these unprecedented times when many of us are relying on online resources for learning.
Scoping Sundays holds a live Twitter session every 2 weeks covering a different topic in endoscopy. And once a quarter, we also host a live state-of-the-art lecture featuring leading experts in endoscopy. We thank you again for joining us today. Before we introduce our speaker today, we'd like to go through some housekeeping rules. So if you have any questions, please type them into the Q&A box below. We will identify the most commonly asked question themes and direct them to Dr. Siddiqui at the end of her talk. We hope to get through as many questions as we can, so please send them in. You can also post questions on Twitter and tag our account Scoping Sundays, and we'll try to answer as many possible live or on Twitter. And our co-tutorial board member, Dr. Mallory Simmons, will be fielding these questions for us.
Now, without further delay, it's our pleasure and honor to introduce Dr. Uzma Siddiqui. Dr. Siddiqui is a professor of medicine at the University of Chicago, and Dr. Siddiqui's training includes medical school at the University of Miami Miller School of Medicine in Florida, where she grew up, internal medicine residency at George Washington University, gastroenterology fellow at NYU, and advanced endoscopy fellowship at Yale University. After serving on the faculty at Yale, she joined the University of Chicago faculty in 2012. Dr. Siddiqui is the associate director of the Center for Endoscopic Research and Therapeutics and the director of the Advanced Endoscopy Fellowship Program. Dr. Siddiqui is also a founding member and current vice president of the Global Society Women in Endoscopy. Last year, she won the Helio Woman Disruptor of the Year award, given a female leader in gastroenterology. Her clinical practice is centered on interventional endoscopy procedures related to pancreaticobiliary disease and GI oncology. She has published on these topics and has been invited for many national and international courses over the years. This year, she published The New Virtual Reality, Advanced Endoscopy Education in the COVID-19 era, and was a co-director of the ASGE postgraduate course at the ACG this year. She also created the Women in Endoscopy Advanced Endoscopy Fellowship Educational Series and is a proud supporter of Scoping Sundays, having participated earlier on in a session on biliary strictures. We are very thankful to have her talk with us today and for her time that she took out of her busy schedule. So thank you, Dr. Siddiqui.
Thank you for the invitation. First, I just want to commend the Scoping Sundays crew, Drs. Chu, Mulki, and especially Dr. Bilal for this amazing initiative and their dedication to education. I think, especially in the midst of this global pandemic, the worldwide virtual GI community that's been built on this platform is amazing. And I think that it's going to have long-lasting effects on endoscopic education. So it is an honor for me to speak to you all today. And as you can see in my title slide, we're going to talk about everything related to the esophagus and how I approach the management of esophageal strictures. We're going to add perforations in there, leaks, and fistulas. I think every GI doctor out there encounters these conditions, and it can often be a frustrating clinical challenge because there's no definitive guidelines for management. So oftentimes we are individualizing therapies, but I'll present what our options are endoscopically and, you know, what are some of the realistic expectations that will occur with our various therapies. Okay. I like to call everything we do a little bit of endoscopic plumbing. I'm having a little trouble forwarding my slides here.
I think you may, the arrow down at the bottom, Dr. Siddiqui.
I'm doing it, but it's not going.
Oh, let's see.
Let me try this. Okay. All right. It seems like a lot of topics, but we have an hour, so we're going to get through all of it, and hopefully you'll come away with at least a few practice pearls. We're going to start off the hour with esophageal strictures. And I think the first thing you need to do is assess your stricture. And the key things that you want to do are try to figure out what is the cause of the stricture, how long has it been there, where is it located? Is it very proximal near the upper esophageal sphincter, or is it more distal? And then what's the complexity of the stricture? Is it a simple stricture where it's short, less than 2 centimeters, straight, it's not very tight, meaning that you can pass a standard endoscope through it? Or is it what we call a complex stricture, which is longer, angulated, multifocal, and the lumen diameter is less than 10 millimeters? And the reason it's important to get a really good upfront assessment of what you're dealing with is because that's going to determine what your treatment options are and how much effort you're going to have to put into this so that you can counsel the patient that this is not going to be a one and done procedure. It may take multiple sessions, and we may never achieve durable success. And especially for these complex strictures that are very difficult to treat, you need to have a plan up front. In terms of etiology, the simple strictures, again, these short ones that are not very tight, are peptic strictures. In this picture, you see a Schatzki's ring, pill-induced, or post-ablation strictures. These usually respond pretty quickly to dilation as opposed to our complex strictures. Nowadays, we're doing more aggressive endoscopic resections with EMR and ESD. And if you do a circumferential resection, you can get very severe strictures. Caustic, lye ingestions, radiation strictures, EOE, and then more recently with more aggressive kind of surgical maneuvers, we are seeing anastomotic strictures that can cause a lot of fibrosis and ischemia and be, again, a clinical challenge to deal with. When we talk about the term refractory esophageal strictures, there's a couple components to the definition. Mike Coachman from UPenn published this in 2005. But basically, you're talking about a stricture where there's stenosis or fibrosis that's causing symptomatic dysphagia in the absence of inflammation. And that's key because inflammation can be treated with medication. So you don't have inflammation in the setting. You're not able to get to a lumen diameter of 14 millimeters over 5 sessions that are done in pretty close sequence at 1 to 2 week intervals, or you're unable to maintain that lumen of 14 millimeters for 4 weeks once dilated. And we use this 14 millimeter diameter as a guide because most patients will be able to tolerate most foods and not complain of dysphagia if you can get over that diameter. So when you're evaluating the stricture endoscopically, a couple things up front. A, you want to make sure it's not cancer, like you see in this picture. If you need additional imaging, you can do an EUS. You also want to rule out EOE because those might be better served with medical management instead of dilation up front. If the patient does have active inflammation, ulceration, then you want to treat that with maximal PPI therapy and then see how the stricture or the inflammation responds to the medication. And for me, if I can't get a standard endoscope through, my goal is always to get as much information to make any potential dilation as safe as possible. So if I can't get the regular scope through, my initial step is to downsize to an ultra thin scope and try to pass that through the stricture to define the distal end. You can also use a guide wire and or fluoroscopy if that's available to you. And if you're uncomfortable doing anything further, you can get a barium esophagram to better define your stricture. But the more information you have, the better. You'll be able to choose the proper tools to dilate. So what are our endoscopic treatment options? Dilation is definitely the cornerstone of treatment for benign esophageal strictures. And again, the simple strictures that I mentioned can usually be palliated or resolved in less than 3 sessions. But multiple studies, and you'll see it a couple times in this talk, show that when you're dealing with those complex anastomotic, radiation, caustic strictures, you are going to need a higher number of sessions to see symptom resolution. And you need to be prepared for it, as does your patient. These are all the different types of equipment that you have available. You have the bougie dilators. Historically, these were used first. The benefits there are they're reusable. There is a taper tip Maloney, which I don't use at all because I always do everything wire guided when I'm dilating strictures, just as a routine practice. So I use wire guided Savory or the American Endoscopy dilators, and the sizes go from anywhere from 15 to 60 French. So again, we're talking, if you divide by 3, 5 to 20 millimeters. And then we have balloon dilators. Those are nice because they go through the scope, but they are single use. There's wire guided and non-wire guided, which for whatever reason is called fixed wire. One thing to know is that depending on the brand, but the wire guided balloons are a little bit shorter, around 5 to 6 centimeters, versus the fixed wire balloons are longer, anywhere from 7 to 9 centimeters. You have the ability to have variable radial expansion. They're usually 3 different diameter sizes, but again, you have ranges between 6 and 20 millimeters. And you can do this with fluoroscopy as well. With both of them, though, you don't need fluoroscopy. It's just something that could be an additional tool if it makes you feel a little more comfortable when you're passing these dilators, so that you can, with the balloons, you can see a waist, and with the Savories or the wire-guided bougie dilators, you can make sure that your dilator is staying within the lumen of the esophagus. So which dilator is best? The answer to that is that, it doesn't really matter, and there's never been data that shows one type is better than the other. So a lot of it comes down to preference. There's no safety or efficacy advantage with either type of dilator. Stricture dilation has a very low rate of perforation in general of about 0.5%. My preference for using balloon dilators are if you have a short single stricture. Again, it's easy to use. I have the option of different diameters, and I can do it under direct endoscopic vision. But usually it's easier to do if you're in the mid or distal esophagus, so that you can see through the entire balloon. It gets harder when you're in the proximal esophagus. If your balloon is kind of in the back of the mouth, it's harder to see what you're doing. So if I have a very proximal stricture, or it's multifocal or very long, meaning more than 2 centimeters, then I'm going to use the bougie dilators, because I'm going to be able to dilate the entire length of the esophageal lumen. And again, you know that you're going to get a definitive diameter in terms of expansion when you pass that dilator down. And you have a little bit more tactile sensation compared to the balloons, where you can feel the catheter going through the strictures once you get to the larger sizes. And then you can hold off once you feel resistance. So in terms of technique, again, I already mentioned, so if a scope doesn't pass through the stricture, you know that the lumen diameter is less than 10 millimeters. So you either downsize the scope, or you use a guide wire, and sometimes fluoroscopy if you have it available. And that's going to help also guide you in terms of what size dilators to use. You're going to start with something smaller. And that's how I usually base my sizing, based on which scope can get through the stricture. Eventually, you want to get to a lumen diameter of more than 16 millimeters. It may not happen on the first session, but again, that's your ultimate goal. Historically, there's been this rule of three, which started in the early days of bougie dilation, where you don't pass more than 3 dilators once you feel moderate resistance. But there's never been any data that shows that this decreases perforation rates, and it's probably not applicable to balloon dilators because you don't have that kind of tactile sensation. And then your repeat session interval is going to depend on the etiology. So if I know this is a peptic or a Schatzki's ring, you know, it resolves pretty well with an initial dilation. I might tell the patient, just call me when you need me. But if I know up front this is an anastomotic stricture, radiation, caustic ingestion, I know it's complex, I know it could be potentially refractory, I will schedule the patient up front for dilation sessions every 1 to 2 weeks times 5 sessions. So again, that's a discussion you need to have with the patient so you can set the expectations for the multiple procedures. And this is just a video of a balloon dilation. And when you dilate, your goal is to cause some mucosal disruption and obviously not a perforation. I believe this was an anastomotic stricture. So we dilated, and you can see here, there is mucosal disruption. At first, you might think a little too much, but if you look closely, you can see all these submucosal fibers indicating, again, there's a lot of fibrosis in that area. It was not a perforation, so you don't have to do anything to close this, but this would be my indicator to stop dilating at this point. And this study was nice. It was published earlier this year. It was a multi-center European study that looked at risk factors and clinical outcomes in patients who underwent dilation, both bougie and balloon, for benign esophageal strictures over 15 years. So we had a nice long follow-up. And again, the strictures that needed higher number of sessions were if you could not dilate over 15 millimeters, and if you had one of those complex type strictures. And at 1 year follow-up, the majority did not need further dilation. And again, perforation was seen in a small percentage. So this just highlights what we already discussed. A couple other therapies that have also been looked at in terms of treating strictures, especially refractory ones, are intralesional steroid injection. Usually we use triamcinolone, and it's 10 milligrams in 1 milliliter, and you inject it into 4 quadrants of the stricture. There's no standardized protocol if you do it before or after dilating. I tend to just do it after I dilate. And there's just been a few limited studies that show perhaps you would need less dilations if you use steroids plus dilation. Other studies have mixed results. But in my mind, it's very cheap. It's very easy to do. So if I know up front, this is an anastomotic stricture, most likely it's going to be refractory, I'll start with steroids and dilation up front. The only times I will not use steroid injection is in a radiation-induced stricture because there are case reports of fistula formation. So steroids I use quite liberally. Incisional therapy is another technique that's been used. Essentially, you use an endoscopic cutting device, whether it's scissors, needle knife, or insulated tip knives. It's not really first-line therapy. Usually you're going to try dilating, steroids, and by the time you get to this, it's usually a refractory stricture. There's very limited data that shows some improvement, but I will say in clinical practice, you get really variable results. And again, you're trying to break through the fibrotic kind of rings in this area, and a lot of times it just reforms afterwards. And that leads us to stents. A lot of people think these are, the saving grace for benign strictures, but I would say not so fast, and I'll show you some of the data. So your options for esophageal stents, there are self-expandable plastic stents, which I have not used since I was a fellow, because these are very cumbersome. You have to backload them onto a catheter. and they're pretty rigid to pass down. But these are the only ones that are officially FDA approved for benign disease and removal. But again, for the reasons I stated, we don't really use these. Nowadays, we always use self-expandable metal stents. These have a very low profile, very easy to pass through strictures, and they have variable levels of coatings to prevent tissue or tumor ingrowth. They're not FDA approved for benign disease or removal. So what we do is just off-label, but we do it in a lot of cases, but it is off-label use. And in Europe, they use biodegradable esophageal stents, but we don't have them in the US. So there's 3 different types of metal stents for the esophagus. There's uncovered, which we would not use in these situations because you're going to get tissue ingrowth and not be able to remove them. So your options for benign indications would be fully covered metal stents. But the problem there is that you get a lot of migration, in some studies up to 50%. So that's something you have to account for. And then since some people are not comfortable with doing any kind of fixation of stents, they sometimes put partially covered metal stents. But the problem there is that if you leave them in for a few weeks, then you can get tissue hyperplasia, even if it's normal tissue, and then the stent may get embedded and you won't be able to remove it. There are stent and stent techniques that you to try to get these out, but this is why I would not advocate using the partially covered stents for this indication. And then with any coated stents, you do have a not insignificant up to 5% risk of fistula development, especially in patients with prior radiation therapy. So you have to be ready for that as well. And now you may resolve the stricture, but you have another issue to deal with. Most of these stents are deployed over a guide wire. Usually we use fluoroscopy. Some people also just pass a scope next to the introducer catheter and watch endoscopically the proximal end deploy. But now there's a few through the scope stents that can be placed through a therapeutic channel endoscope. And again, in some cases may obviate the need for fluoroscopy use. So what are the outcomes when you place stents for a benign refractory esophageal stricture? Well, they're not that great. There are definitely mixed outcomes. See here, the overall success rate never goes above 50%. Depending on the type of stent you use, you have high migration rates. And again, you have fistula formation and radiation in patients who had radiation. You can see perforation and the dreaded stent embedding that can make it difficult, if not impossible, to remove a stent. So we still haven't found 100% great therapy for these refractory strictures. And I mentioned earlier stent fixation. So I like to put fully covered metal stents because I know I can remove them, but I know they're going to fix them. So what are the different options for fixating your stents? You can use clips, both through the scope and over the scope, and you can use suturing. So in terms of hemostatic or through the scope clips, there's all different brands out there. And I think it's important, especially as trainees, to know what the different brands are, because the clips open anywhere from 11 to 16 millimeters. They all have different characteristics and can be different in terms of how you deploy them, the length of the clip body itself, which may obscure your view or be hard to use esophagus. They have different ways of rotating, whether it's you rotating it yourself versus your assistant. So these are all things that you should know ahead of time so that you can choose the proper clip or one that you prefer. And there has been a study where they looked at using regular clips for preventing stent migration, and it showed that the not clipped stents definitely had a lower rate of migration, no complications, and there was no problem retrieving the stent or pulling off the clip to retrieve it. I personally haven't had that much success with regular clips, but we have used over-the-scope clips. In the US, there's 2 different brands, the Ovesco and the Padlock here. You see this star shape that have been used, but sometimes it's hard to get them onto the stent itself. So just recently, there's a newer stent fix over-the-scope device that has a flatter edge that allows you to go under the stent and then deploy the clip on top onto the mucosa. But again, these are all loaded onto the outside of the scope, similar to a variceal bander, and then you just turn the knob to deploy them. The main issues may be in terms of removal. In the past, you either really yanked really hard and hoped there was no mucosal injury, or you could try high-powered APC, but that can be very cumbersome. There are now a specific generator device that allow you to break these clips, but again, it's an added expense. And again, there has been studies that show if you use over-the-scope clips, they're going to prevent migration in benign conditions. And here you can see the clip. So it is very useful, but the removal is the main issue in my mind. So I do prefer suturing. It has been shown to decrease stent migration rates in some smaller series. The current device in the US uses a double channel endoscope. There is a newer one that goes on a single channel scope, but most of us use this double channel one. And this is just a video showing the suturing to the stent. Usually you'll just put a bite into the normal esophageal mucosa, a bite into the stent, and then another bite into the mucosa. And if possible, you can put 2 sutures to ensure the stent is fixed. And it's pretty easy to come back in a few weeks or months and just use scissors or loop cutters to break the suture and pull the stent out. And again, there has been data showing that that if you suture your stents, you will have less migration. And on average, it only adds about 12, 15 minutes to your procedure, if that, once you become pretty adept at placing these sutures. So this is what I like to do. If I have a benign refractory stricture that I'm putting a stent in, I like to use the fully covered stents, and then I will suture the stent at the proximal end to prevent migration. In my own experience, the clips have had variable success. And then I'm going to leave the stent in for a longer period of time of around 3 months. If you were to place a partially covered metal stent, you do have to remember that A, there can still be migration, and B, you may get tissue ingrowth that's going to cause the stent to embed. So if you're going to use this type of stent, then I would advocate for a shorter length of time. But then that may not resolve the stricture. So you have all these risks. Some considerations, if you are suturing or clipping these stents and you're disrupting the coating, then you may see some separation of the metal joints, especially in these laser cut through the scope stents. I would not put your scope through the stent lumen during the procedure because you may dislodge your stent. And the main issue is that oftentimes the space that you're working in is really tight. So if you have a really high proximal kind of stent placement right near the upper esophageal sphincter, you really don't have any options to fixate because you can't put a clip, or you definitely cannot fit the suturing device into that high up of a location. And also, if you're dealing with a narrowed lumen in general, it may be harder to maneuver around the stent. But basically, you take what you can get, and your goal is just to get some normal mucosa and stent. So what are some, a little bit newer things that have been tried for strictures? There's been a lot of use in the pediatric population of mitomycin C, or I won't say a lot, but more published data, where you have these pledgets that are on the outside of the scope that are kind of doused in the mitomycin C, and then you pass it through the stricture and just kind of try to coat them. And it's shown that post-dilation application of the mitomycin C has favored symptom resolution and less number of dilation sessions. So it's something to consider. There are costs involved, and in our hospital, they made this a chemotherapeutic drug, so you need special training before they'll let you use it. And then more recently, especially when we're talking about anastomotic strictures, which again can be clinically challenging to resolve, there has been use of lumen-opposing metal stents, because in theory, they seem perfect because you have a short stricture and then you have a short diameter stent with really large dumbbell flanges. So the hope is that you will not have migration and it'll stay in place for a longer period of time. Most of the data has been using these stents in post-gastric bypass patients, but there have been reports and smaller series where it's been placed in the proximal esophagus, especially after esophagectomy. I will say the rate limiter that I've seen in our practice when we've used these very high up is that the patients complain of severe pain. And I think it's because you have such a short distribution of force over this really short diameter stent, and the patients, you know, they would rather have the stent out and not swallow than keep it in long term. So we've had to pull them out quite early. But again, there is some limited data to suggest that perhaps you can use these. And not to be kind of a Debbie Downer, but this study out of Italy a couple of years ago kind of shows and demonstrates everything I've just been talking about and the difficulty in dealing with these refractory strictures. So they had 70 patients that, again, they followed over 15 years for a median of 44 months follow-up. And so they defined successful resolution as no intervention for 6 months. They had a median of 15.5 dilation sessions. So again, this shows you how much effort you're going to have to put into treating these refractory strictures. That is a lot of dilations. And in 40%, they even placed stents. But unfortunately, they only showed stricture resolution in about a third of patients. So you need to keep this in mind when you're dealing with these patients. But on average, you could get patients to be symptom-free for about 2 to 3 months. So you probably have to plan with the patients in terms of just scheduling repeat sessions to try to keep them eating normally. Okay, we will move on to perforations, fistulas, and leaks. I think it's important when we're talking about these different entities to know, exactly what they are. So when we talk about perforations, we're all familiar with this concept. You have an acute, complete, or full thickness defect of the GI tract wall, and it requires urgent therapy, especially in the esophagus, because you have potential for contamination of the mediastinum or abdominal cavity. It can be an adverse event from endoscopy, or sometimes you do it on purpose, like in a poem where you're making an entry into the submucosal space and you're going to close it after. And this is in contrast to a fistula, which occurs over time. It's a chronic condition, usually an abnormal communication between two organs, like a tracheoesophageal fistula. Usually the mucosa is going to be ulcerated or fibrosed. And then you have a leak. That's a post-operative adverse event where there's a defect of the surgical anastomosis resulting in a fluid collection or abscess. And in these cases, depending on when you diagnose it, you may have more healthy tissue adjacent to the defect versus scarred or fibrosed tissue. And the most important concept here is that the success of your closure attempt is going to be completely dependent upon early recognition and the condition of the esophageal mucosa. If you recognize it early, there's healthy tissue, you're going to close it or divert secretions, and you're going to have a really high success rate in terms of closure. And if it's something chronic, inflamed, fibrosed mucosa, you're going to have a really hard time and you may never achieve success in terms of outcomes. We mentioned earlier that you can have significant morbidity, mortality related to infectious complications. The quality of life of some of these patients with chronic leaks and fistulas can definitely be reduced. It often takes a multidisciplinary approach with discussions with your surgeons and interventional radiologists. And endoscopy does play a major role in the management. And I'll discuss these in more detail later, but your two major goals of therapy are either primary closure of a defect and or diverting GI secretions. But in general, we have limited data. There's no standard algorithm, and every case has to be treated on an individualized basis. So for perforation, obviously we all perform endoscopy and it does have a risk of perforation. Luckily, the rate of perforation from a routine EGD is going to be less than 0.1%. But once you start doing more aggressive therapeutic maneuvers, your risk for perforation goes up. Again, stricture dilation, still pretty safe, about 0.5%. EMR, the risk goes up to 1%. And then once you're doing ESD, your risk can go up to 5%. The other things that can cause perforation in a therapeutic practice, or if you're passing a side viewing ERCP scope or oblique viewing EUS scope, and there's a stricture or luminal narrowing that you may inadvertently push the scope through, and that can cause a perforation. I think the most important things, you know, in terms of managing or preventing perforation starts before the procedure even. Do you have a good clinical indication for the procedure? Is there informed consent that's talking about this as a potential adverse event? Make sure you know what devices are available in your unit and that everybody, including you and your staff, know how to use them. And then know your endoscopic limits. What are you comfortable with in terms of managing? A lot of us, you know, when you think about perforation, the first things are that you feel terrible and you're very nervous and anxious about it. But again, if you can pick these things up early and not freak out, you have a very high chance of managing them successfully. So that includes your assessment during the endoscopy. You know, sometimes you get nervous if you do a dilation, there's a lot of bleeding or mucosal disruption. So your first instinct is to just pull the scope out. Or when you're doing bougie dilations, you don't want to look after the dilation. But I would highly encourage you to always inspect your dilation site for any kind of perforation. And I always spend a few extra minutes looking at it. Because if there is a perforation, you want to know how big it is, where is it located, and what's the appearance of the surrounding tissue, because that's going to determine what therapies I have available and what I'm going to do. If the patient's already on a fluoro table, then you can inject contrast to try to identify where there's extravasation. And a lot of times, if you do a dilation, there may be some bleeding. And so I always try to wash the blood away because I want to make sure to clear the area and visualize the mucosa. And not everyone does it, but after even bougie dilations, I always pass the scope again, which sometimes is pretty scary, but I like to look at my dilation site. This was a post circumferential EMR that my partner had actually done and then was out of town, and the patient developed a bad stricture and I dilated them. And there was a defect that I noticed at 1 o'clock there. And because the surrounding tissue is ulcerated and fibrotic, it really couldn't be closed with clips. So what do you look for? You know, say you didn't recognize it during the procedure itself and the patient's in recovery, but they start complaining of chest pain, neck pain. You notice crepitus on physical exam, or obviously if there's hemodynamic instability, tachycardia, fever, those things may indicate mediastinitis, peritonitis, sepsis. What's the workup that you do in terms of imaging? You have options depending on your institution and what you can get done quickest. You can get an esophagram with a water-soluble contrast like gastrographin, not barium, because you don't want to cause mediastinitis. If there is a perforation, here you can see a contained perf there. Or sometimes it's quicker in your hospital to get a chest CT with oral contrast. The advantage with chest CT is that you can also look for air and any fluid leakage into the lungs. And this is kind of a summary that's been adapted that looks at the ABCs of perforation management. Again, air by itself is not an adverse event. If you were to scan everyone after some of the maneuvers we do, you might find a few air bubbles, but it depends on the patient's clinical status. I always use CO2 for all my endoscopies. If there is a known perforation, you're going to give antibiotics. You can adjust the patient's bed position to minimize soilage. If you perform a primary closure, you're going to need a contrast study later to ensure that it's durable. You can divert contents. And again, those are the two principles of management. If they have collections, you may need drains. Think about how you're going to feed this patient. You may want to consider putting in feeding tubes. And if there's gross soilage, sepsis, closure failure, then you're going to need to get your surgery colleagues involved. And it also depends on where the perforation is. So if you have a cervical perforation, you need to know that you're going to consult your ENT colleagues versus something that's lower down where your thoracic surgery colleagues will be involved. And then depending on how close you are to the upper esophageal sphincter, that's going to determine if you can close this endoscopically or place a stent. Because if you're right up at the UES, you're not going to have as many endoscopic options. And the good news is if you have a cervical perforation, usually these patients respond to conservative management because you have a contained space. So they're not going to get mediastinitis or peritonitis. Again, you're not going to have enough room to do a lot of endoscopic therapy, so supportive care. But if you have a lower perforation, then those are the ones you need to have aggressive management on because there's a very high mortality. You need to get your thoracic surgery colleagues involved, NPO, IV antibiotics, and then again, we'll talk about our different endoscopic therapies. And in terms of fistulas and leaks, here the clinical presentation can be a lot more subtle. With TE fistulas, they may have coughing, every time they try to drink or eat something, fevers, and recurrent aspiration pneumonias. And then anastomotic leaks may have fever, tachycardia, elevated white count, or increased output from chest tubes. So you have to be a little bit more on high alert in terms of picking up these lesions. And especially with anastomotic leaks, earlier the recognition, the better the outcome. Again, diagnosis is similar, esophagram or chest CT with oral contrast. Here you can see there's a lot of fluid leaking into the lungs. Bronchoscopy may pick up tumor invasion. And then endoscopy can pick up a fistulous opening and allow for potential treatment. Here's a big fistulous opening into the pleural space. So our endoscopic management, I mentioned it before. Our two options are going to be primary closure versus diverting GI secretions. So the primary closure is going to be best for those acute perforations where the tissue is healthy or a very early anastomotic leak. And smaller size, healthy surrounding mucosa. And then if you're going to just divert the secretions, sometimes we'll do primary closure in addition to diversion with stents. But these can be used for anything, especially if you have fibrotic and scarred tissue. In terms of primary closure, your options are clips or suturing. We talked about the different types of clips. Usually what you want to do is start with suturing or clips, but you would start distally. You often need multiple clips and you want to close it in a zipper fashion where they're close together so that there's no gaps between the clips. And this is an example of a perforation that was caused by a fellow passing an EUS scope. And it was about, I would say, 5 centimeters below the UES. So we had room to place a clip. You can see the defect at like 5 o'clock. And because it was a little bit higher up, I think the choice for through the scope clips was easier in terms of placement. The over the scope clips have a little bit larger diameter on the scope, so it may be a little harder to visualize well. And make sure that you're not grabbing the other wall. So through the scope clips were placed and the perforation was closed. Again, the surrounding tissue, completely normal, so you know you're going to have a good outcome. Now, over the scope clips have been great, especially for those larger caliber, over 10 millimeter defects, up to maybe 20 millimeters. Again, you have your different brands, and there has been data to show that they are successful in terms of closing perforations. This was a case of a Boerhaave where a patient had severe retching, vomiting, and had a spontaneous perforation. The Ovesco was placed on the scope. And there's also forceps that has independently moving arms that you can use to bring the tissue in. There you see the full thickness perforation there. And here's the dual grasper. This is nice because since the arms operate independently, you can grab one side of the defect and then move your forceps over and grab the other side, and then you have to bring it into the cap. The key thing here is make sure that grasper is all the way inside the cap, because you do not want to deploy the clip and onto the grasper, because then you're stuck on the mucosa. So you see them bring it all in. Again, the tissue surrounding the perforation is healthy, so it very easily can be suctioned into the cap. When you're dealing with fistulas and chronic inflammation and fibrosis, you will not be able to suction into the cap, and then those are not going to have a successful closure. Usually if I do primary closure, I'll still put a stent after just to make sure that there is healing. Again, there's been a couple small studies looking at through the scope clips versus over the scope, and over the scope were better for those larger 10 to 20 millimeter defects. But again, low rates in terms of treating fistulas and chronic leaks. And suturing for primary closure also is another technique you can use. This was a perforation after a savory dilation that was discovered in recovery because they did not pass the scope during the procedure. Here, again, you want to start distally and then work your way proximally to close the defect. And you can do a double layer kind of closure for thoroughness, just to make sure there's no leakage. And you see a tissue helix device that kind of embeds into the tissue like a corkscrew, and then you bring it back into the housing unit so that you grab a full thickness bite. And we'll just kind of skip towards the end of the video. And you take a couple bites, and then at the end, you're going to cinch it closed. But again, I would still put a stent after this. And there you can see you've closed the defect, and a stent was put after this. The other thing in terms of diverting GI secretions, some people use APC, and I try to, if I remember, to try to kind of allow for mucosal healing to bring the tissue together. And if there's staples or sutures, try to remove those because they can cause a foreign body reaction. Again, if you place metal stents and you use fully covered ones, you have to fixate them. But if it's really high, you may not have enough room. And if there's any kind of respiratory compromise, you may want to consider stenting the airway beforehand. Sometimes if there's collections and a big defect through a fistulous tract, you can also place pigtail stents to allow for drainage, like you see in this photo. The stent data, again, for perforations is amazing, 100% success, but around 50% or less for fistulas and leaks, especially those anastomotic leaks that are picked up late. Higher rate of migration, again, with the coated stents, but no real difference in terms of stent, in terms of outcomes, depending on stent type. And we will say it one more time, higher rate of success if you pick up a perforation or leak early, because the mucosa is going to be healthier, and if you have a smaller defect. And then there's a couple off-label techniques and devices like glue, vacuum therapy, or a cardiac septal occluder for TE fistulas. Again, very, very limited data and just a few case series. And I will conclude with that. So, I think as we're becoming more aggressive in terms of our endoscopic, surgical, and oncologic therapies, we are seeing strictures, perforations, fistulas, and leaks more often. They can lead to significant morbidity and mortality and poor quality of life for patients. So for you as a GI doctor, when you're assessing and treating these things, I think the most important thing is to assess the lesion up front: size, location, mucosa health. And all of those factors, and including the time to recognition, is going to determine your outcome. You need an individualized approach to each of these patients. Often you're going to include your colleagues in other fields for a multidisciplinary discussion. Endoscopic therapy does play a major role for all these conditions, with clips and metal stents playing the biggest role. But we still don't have a ton of data on the different endoscopic therapies. And, again, we don't have definitive management guidelines. So we still need more data, and we're always looking for better tools. Thank you. I'll stop with that.
Thank you so much, Dr. Siddiqui. That was an amazing talk. I think we all learned a lot, and you've stimulated a lot of conversation. We have a lot of questions, and we're going to try to get to as many as we can. So one question that we got, a common question, was, what about the etiology of the stricture, and how does that play into the timing? For example, how soon would you perform endoscopy after a corrosive ingestion?
So again, if I know upfront it's going to be a complex stricture, I'll probably bring that patient back pretty frequently in the beginning, like every 1 to 2 weeks in the beginning. If it's just a peptic or Schatzki's ring, that one is just kind of a PRN basis. But everything else is going to need multiple sessions, and I bring them back very aggressively, and like I said, every 1 to 2 weeks, which is oftentimes annoying for the patient, for sure. But I think it helps up front if you have a discussion with your patient and say, look, this stricture has been there probably for years. You've been having symptoms. I'm not going to solve this problem in one session. So, work with me.
Thank you, Dr. Siddiqui. We have another question. In those patients that you place the stent in that don't tolerate it for pain or foreign body sensation, do you have any tips or tricks in managing these situations?
Well, my partners say I'm cruel. I just tell the patients, get ready for it, and I leave it most of the time. Some people use a little bit smaller caliber, especially in the proximal esophagus. Some people also may try one of the laser cutter through the scope stents, which may have a little bit less kind of radial tension or pressure. So some patients may notice a difference when you use those types of stents, or again, just going with a smaller caliber. But I warn the patients, even my cancer patients, when we put the stents in, there could be very significant pain. And I find the pain's worse the higher up the stricture is, or the stent placement is.
Thank you.
Dr. Siddiqui, could you comment on whether there's anything we can do to try to prevent development of esophageal strictures after ESD?
Oh, that's a great question. Everyone has looked at everything possible, from, injecting steroids into the resection site. The Japanese give oral steroids in some cases, and nothing has proven definitive, though. I think it all depends on, again, how aggressive your resection is. If I'm doing an EMR, I probably won't go more than 50% of the lumen in the first session, just to allow some healing and prevent strictures, perhaps. And if you're doing an ESD, if it is a circumferential lesion and you can't get around, a complete 360 resection, I think the patient has to be, informed about the stricture formation rate and the difficulty in treating them. But there's nothing definitive, but those have been, intralesional steroids and oral steroids have been looked at.
Thank you.
Thank you, Dr. Siddiqui. There is another question about the management of chronic leaks. How do we define chronic? And then if you have any experience with endovac using this situation.
Well, the first one, the endovac, I don't have that much experience with it. My partner had one patient, he used it in. You have to borrow the tools from other areas in the hospital, and it required repeat procedures every couple of days, and it was a huge collection, and we didn't see that much improvement. The data out of Europe, though, looks very, very promising. So they probably perfected their techniques a little bit more, but I don't have that much experience with it. But it does require multiple procedures, some sort of external drainage often, and then in addition to keeping a tube down. So those are all considerations. And then what was the first part of the question again?
How do you define a chronic, chronicity? Is it, specific time interval to define chronicity?
I mean, we know that any leak, if you can pick it up and initiate therapy, within 48 hours, that's ideal. So once you start getting beyond that, I don't know if I would say a certain time frame, but the longer out you are and the more inflammation and fibrosis and destruction of the adjacent tissue that occurs, the lower chance of a successful outcome. So I base it more on the condition of the surrounding mucosa. But if you can, especially for anastomotic leaks, our surgeons are very sensitive to, fever, tachycardia in the patient. You need to be on high alert for a leak, and that should prompt some sort of imaging. We get a lot of transfers from outside hospitals where the patient had symptoms, but nothing was done for a week or so because the patient was otherwise, quote unquote, stable. And then it becomes much harder for us to treat when we see the patient weeks later.
Thank you.
So Dr. Siddiqui, we have a lot of questions about esophageal stents. I'll mention just a few to start with. So one question is, how long do you keep esophageal stents in place before removing them? And how do you decide whether to place another one? And then when you place the stent, do you need to check the stent position the next day? Then thirdly, if you do get a stent migration, for example, if you forgot to place a clip, what do you do then? Do you need to do anything if the stent migrated to the stomach?
Okay, so first, again, I usually do fully covered metal stents. I usually fixate with a suture just because I'm comfortable with that technique and I find it easy to remove the sutures or break them after for stent removal. I usually leave it in for about 3 months on average. I'm always worried about fistula formation. In a lot of patients, if they've had radiation before, you definitely need to mention it to the patient. But I leave it for about 3 months. Then I bring the patient back and I want to remove it. Again, just to give that tissue a second to breathe and just look at the underlying mucosa, see if we have stricture resolution, meaning is the diameter above 14 millimeters, where I think the patient's going to swallow essentially normally, then, we can try them without a stent. If it's less than that, then I would probably replace the stent, bring them back in 3 months again. Or sometimes you can increase it to around 6 months. I would never go past 6 months. Again, I'm always paranoid about fistula formations. I've had TE fistulas. I've had aortoesophageal fistulas, which is, the patients die once they get that. So even if you pick it up early and get to surgery, the morbidity is quite high. So I'm always worried about those when you're leaving in the stents long-term. If the stent migrates, it's usually not a huge deal. It can sit in the stomach for any length of time. Most of the time, these stents will not pass through the pylorus, the regular stents. I will say the laser cut ones that you can put through the scope, those are very slippery. And I have had a few patients where those have migrated completely out of the patient. But the other standard non-through the scope stents tend to sit in the stomach. Over time, the acid will start eroding any coating, but you can remove them. I like to use a large caliber snare, like a 30 millimeter, and then I put it in the middle of the stent, and then I pull back so that it causes the stent to go into a V, which allows you to pull it through any residual stricture a little bit easier than if you just grab it at the end and pull, because that's the hardest part. If the patient still has a stricture, how do you get it out? So if I can't get it out through the stricture, I would place another stent, leave it in for a while, dilate up the stricture, and then try again on the next session.
Thank you, Dr. Siddiqui. I think we have time for one more question. The role of needle knife stricturoplasty in
It's useless. I just haven't been impressed with it. Again, by the time you're getting to that step, this is already a refractory, hard to treat stricture. And you know, in my own practice, I've seen variable success. It's probably the equivalent of flipping a coin, if it works or not, because the level of fibrosis is what's going to cause that stricture to recur. And it you know, again, may not respond long-term to the stricturoplasty. Short-term, yes, but long-term, I think variable success rates, which is why not everyone does it all the time or routinely.
Thank you.
All right, thank you. So we're running out of time here. Please feel free to continue to ask questions under the Scoping Sundays Twitter handle, and we will answer and forward questions on to Dr. Siddiqui. We'd love for the discussion to go on. And, you know, thank you again so much, Dr. Siddiqui, for your time. And thank you, everyone, for joining us.
On behalf of Scoping Sundays and all the trainees in the US and around the world, Dr. Siddiqui, thank you so much for taking the time off to give us this fantastic talk. Thank you.
No, I was going to say, as someone who's had now a 15-year career, the success of your career and your clinical practice is often dependent on the colleagues who you meet along the way and who support you. So kudos to you guys in Scoping Sundays for making your supportive network worldwide. And even in a pandemic, you know, you're keeping the learning going. So thank you for letting me be a part of it. Appreciate it.